Yeah, so we like to have the full suite of myopia management available in the practice. And so, we've got access to all the different myopia control soft contact lenses, myopia control spectacle lenses. We've been doing Ortho-K as a myopia correction and myopia control device for over 20 years now. And we've introduced a red light therapy into the practice. So low-level red light therapy is probably one of the newer ones. And what we're now getting is improvements on some designs. So version 2 of some lenses out there. So we've been lucky enough to been given early access to the MyoSmart IQ. So Hoya is a lens company that brought out the MyoSmart lens that did a pretty good job of myopia control, and they've improved the design further. And so the research has really indicated a significant reduction in the number of people who are progressing. And so we're sort of seeing, we're excited to be able to kind of see how much we might be able to slow things down even further than what we had available, even just a few years ago.
So maybe you can just briefly explain how do those myopia control lenses, spectacle lenses, like how do they work? What's the mechanism that slows down axial length progression?
Yeah, look, and most optical methods of slowing down progression work on some sort of way of doing peripheral defocus. So putting a different image shell, they call it, on the back of the eye that's different to the part of the focal length that keeps you seeing clearly. So, and what they've worked out is that if you provide a different type of defocus to the peripheral part of the retina, and if we look at the retina as just, I like to say to patients, it's a bit of brain that you point at things. And so it is registering not just whether things are clear, not just whether things are moving, but also what's the relative distribution of light. And so by altering that with these lenses, then it's switching off the signals for the eyeball to grow longer than it should. And so if you hold if someone's wearing a myopia control lens, often you can't see the lens looking any different to a regular corrective lens. But if you hold it up to the light, you'll see these little dots in the mid-peripheral part of the lens. So you've got a central area to see clearly through, and then you have these little dots that provide that peripheral defocus to sort of switch off the growth triggers at a retinal level.
Yeah, my nephew wears those spectacles, and unless you look really close, you really couldn't tell the difference between any regular pair of glasses.
Yeah. So from a cosmetic point of view, there really aren't too many issues with them. Some kids might need to just get used to those dots being there, but on the whole, the vast majority of people who wear them get used to them within a couple of weeks.
And some parents may have heard of or even have experience with the eye drops, atropine eye drops.
Atropine, yeah.
Yeah, and so maybe there are cases where you prescribe that as a standalone treatment, or perhaps more commonly as some sort of combination treatment. Do you want to just talk about that a little bit?
Yeah, look, so we've been probably a little bit more conservative around atropine, because if you use a higher concentration of atropine, the higher the concentration of atropine you use, the more side effects there are that create discomfort in terms of the pupil being big and light sensitivity and those sorts of things. And in the higher concentrations, there's a fair dropout rate. And when you look at what's available now, once you reduce the atropine concentration down to a level that's tolerated by a majority of people, you're talking about efficacy of its ability to control myopic growth being very, very similar to what you get out of a myopia control contact lens or a myopia control pair of glasses or Ortho-K. So they're all become sort of fairly even at that particular level. So we've kind of gone, well, if you have to correct eyesight anyway, why don't we just use a myopia control lens, and then atropine becomes something that we add into someone who might still be progressing at a fairly fast rate. And that makes it more convenient because you're not having to go off and get the specially made compounded product sort of every month. And so it just simplifies things if, we're just using it as what we call an adjunct therapy.
So putting drops in your eye might help in some respect, but they're not going to help your child see the whiteboard any clearer. So they're still going to need glasses at the end of the day.
At the end of the day, and if you were somewhere where you didn't have access to good myopia control optical devices, and certainly there are surprising things like places in the US where they just don't have access. This is where we're really lucky in Australia. And they just don't have the same access to myopia control optical devices like we do here. And so, they lean into needing to use atropine a lot more with just regular sort of sight correction.
So does atropine like dilate the pupil more? Is that how it works? And if so, is that potentially like exposing the back of your eye to a bit more UV?
That's where you need to be a bit more careful with using it. And so, and again, as you go up in higher doses, the bigger the pupil tends to be. You're going to get some UV protection from your lenses and your glasses, but it does mean you need to be a lot more sort of careful around, making sure you've got a hat on, using sunglasses outside, those sorts of things, not just from a comfort point of view, reducing light sensitivity, but also just, that UV risk.